All right, well, good evening, everyone, and welcome to the third meeting of the Western Pennsylvania Society of Thoracic Surgeons. Absolutely delighted to have everyone here. My favorite part of the meeting is walking in and seeing people who I haven't seen for weeks, months, or a few hours. And the least favorite part of the meeting is to start talking over everyone, cutting the chatter. But we'll get on with our program so we can get back to interacting and spending time with each other. First and foremost, again, thank you to all the members and all the surgeons and trainees in the community for coming and spending time with us this evening. This really is about you all and to hear from each other and to learn from each other. I really want to take a minute to thank all our sponsors, our industry sponsors. We really cannot do this without their support. They've been loyal supporters of the community and our hospitals and our surgeons for a long time, and I think with CT surgery, particularly cardiac surgery, being such a device-heavy specialty, it's hard for us to be able to do anything without their support. Here are our contributors. Please feel free to stop by their booths. Thank everyone for their support, and we really appreciate it. Again, thank you to all the leadership for the society, Andy, Steve, Hiro, and special thanks to Angie, who really, as you all know, does really all the work. So really a special round of applause for her to putting this together. We have two special guests tonight. Again, we've started a theme of having somebody from outside of Pittsburgh come share their experience with us. So we're absolutely honored to have Tom MacGillivray here with us. And the second part of the program is having a surgeon who spent time in the community. And so since the very first day I landed in Pittsburgh, there's a few names that always resonate as kind of the legends or the surgeons whose shoulders we all stand on. And Ron Pellegrini, Masharaju, McGovern. I mean, those are names I kept hearing over and over again. So it's really an honor. And thank you, Dr. Pellegrini, for coming and spending the time with us. We really look forward to the chat. So we'll start with Dr. MacGillivray's talk. And again, we're privileged to have him here. Dr. MacGillivray, as you know, is the chair of the Department of Cardiac Surgery at MedStar Washington Hospital in D.C. and the vice president of medical operations. His CV is several dozen pages, and so is his bio, so I'll stick to the brief, interesting parts. He was a classical studies major, which I just learned, at Tufts University and earned his medical degree there. He then completed his general surgery residency and CT surgery fellowship at Mass General Hospital, followed by a fellowship in fetal surgery research at UCSF and congenital heart surgery at Boston Children's Hospital. He's board certified by American Board of Surgery and Board of Thoracic Surgery. He began his career on the faculty at MGH, where over the span of 20 years, he has had virtually won every clinical accolade, led every single clinical program at MGH. In 2016, he left MGH and was recruited to be the department chair at Methodist Hospital, where he also served as the Jimmy Howell Endowed Chair of Cardiovascular Surgery. After which, in 2022, he moved to MedStar in Washington. And I've heard this from not one, not two, but three surgeons, that when Tom left Methodist Hospital in Houston to come to MedStar, they had to hire not one, not two, not three, but four surgeons to do the kind of work that he's doing. And it tells you that he truly is a consummate surgeon, somebody who does a redo CABG one day, a thoracoabdominal the next day, a lung transplant the third day, and a congenital heart operation the fourth day. I think those surgeons just exist in textbooks, as far as I know. So it really is wonderful to have him and talk about his experience. He really has been a Renaissance surgeon, as you can read from his contributions to the medical literature. And in talking to him and getting to know him a little bit, when you ask him what his greatest accomplishment has been, it's not, he rarely speaks of the professional accolades he's won and all his professional accomplishments. He always talks about the greatest privilege of his career, which is the patients he's had the privilege to take care of. So thank you, Tom, for coming here and spending the evening with us, and looking forward to your talk.
Well, Yves, thanks so much for that generous and I would say embellished introduction. Thank you. It's really a great pleasure to be here, and it's great to see so many old and good friends. It's fun to run into Arjun Penethur, who back in the day we were general surgery residents together, and my old general surgery resident, Karen Kim, and Stephen Waterford are here. Great to see Victor Morel. So many old friends, and nice to meet new friends. I can't tell you how great I think having these regional meetings are, where everyone can get together. Although, you know, as cardiothoracic surgeons, we tend to compete. I don't know if that happens here as it does in some other parts of the country, but to compete in a collegial way and a collaborative way, I think is a win-win. It's the best of all worlds. It's an honor and a privilege to be invited to speak here tonight and to be with you. I'm really looking forward to hearing Dr. Pellegrini's talk. I tell you, it's a thrill is to be on the same placard as Franco Harris. I only wish my old football coach could be here to see that. He grew up in Pittsburgh. He played for Pitt. He was an All-American at Pitt and was played for 2 years with the Pittsburgh Steelers. And I can tell you back when I was playing, I'm not sure he would say I played for him, but I played on his team. And so shortly back with Franco Harris and Terry Bradshaw and Joe Green, the Immaculate Reception and the Steel Curtain, that with all due respect to Dallas, I would say that the Pittsburgh Steelers were America's team. They certainly were our team with Fred Glatz. So it's great to be here. And so for tonight, I was just going to talk about aortic dissection and what's newish in aortic dissection. As they used to say in Houston, there's nothing new in cardiac surgery. Everything always went back to Dr. DeBakey, but I do think that there are some new and interesting things that are happening in the management of aortic dissections. I don't have any disclosures or conflicts of interest to make. So, and then just over the next 30 minutes or so, just to talk about both type A and aortic and type B aortic dissection, go over some of the changes in the classification systems, talk about some of the controversies and how we manage these patients in the operating room, both with cardiopulmonary bypass and cerebral protection, as well as the root and arch management and malperfusion and new things in that, as well as with type B dissection, talking about what we know and what we thought we knew, and hopefully not to make it too boring. So it's interesting that the first reported case of an aortic dissection was a CPC, and it's King George II. King George II was the King of England during what was known as the 7-Year War. In the Americas, it was known as the French and Indian War, which I understand was the most expensive war up until World War II. And the cost and trying to recoup that cost is what led to all the taxes and ultimately the American Revolution. His successor, King George III, who was his grandson, was the King of England during the American Revolution. But King George II got up one morning, went to the bathroom. Some of his butlers heard a big thud, and they went in and they found him dead on the floor. And Dr. Nichols, or Mr. Nichols, did an autopsy on him and made the diagnosis, the first CPC, I said, of a aortic dissection. He died of a ruptured type A aortic dissection. As I think many of us know, type A aortic dissections are the most common catastrophe of the human aorta. It affects about 3 in 100,000 patients. It's a life-threatening condition, and we've all learned in medical school that every hour is a 1 to 2% mortality. And survival is improved with not only prompt but effective diagnosis and therapy. I think Dr. DeBakey made some big impacts in how we manage patients with aortic dissection. His classification system, the DeBakey system, type 1, tear in the ascending aorta affects the arch, and descending aorta type 2 isolated to the ascending aorta, and type 3 involves the descending aorta. The Stanford system, like everything in California, simpler. Type A involved the ascending aorta. Type B did not involve the ascending aorta. And the beauty of both of those classification systems that's still used interchangeably is it helped us understand, at least categorically, the prognosis of the disease and the treatment of the disease. Type A dissections got operations. Type B dissections, at least in the last 40 years or so, did not get operations. They were treated medically. As we have learned more, and as the specialty and the therapies have evolved, our classification systems have also needed to change. A few years ago, the Society for Vascular Surgery and the STS got together with not just the advent, but the evolution of endovascular solutions for particularly type B dissections, and I dare say infringing on the ascending aorta as well, understanding how to manage entry tiers and then the proximal and distal extent, important so that you can cover the entry tier and have proximal and distal landing zones. So the SVS, STS classification system, entry tier, whether it's in the ascending aorta or zone 0 is a type A. Anything that's in zone 1 or distal is a type B. And the proximal extent of the dissection is a subscript as a number, depending upon the zone, and the distal extent, the number according to the zone. I think maybe the most relevant is the European, the TEM classification. And I say it's the most relevant not just because they have share my initials, but it breaks it down again as to type of dissection, whether it's type A, involves the ascending aorta, type B, the descending aorta, and unlike the other classification systems, does address the aortic arch, a non-A, non-B. So if you have a dissection that involves the aortic arch and the descending aorta, but not the ascending aorta, it's a non-A, non-B dissection. The E is the entry location, as you can see in the cartoon, according to the zones, and then malperfusion, whether it involves no malperfusion, coronary malperfusion, supraaortic vessels, or the more distal vessels, whether they be the spinal, mesenteric, or visceral vessels. I think we've appreciated for many, many years that the surgical treatment of type A dissections is associated with a much better prognosis in survival than medical management. So that not only is it surgical management, but emergency surgical management once the diagnosis is made. And the goal of surgery is to, if I can be so bold, is to keep the patient from dying of their dissection. And it's not to take out or to control the whole dissection. It's to manage the problems that can kill the patient. What kills patients most commonly with type A aortic dissections? They rupture, and they exsanguinate, or they get tamponade. They have malperfusion, whether it be coronary, cerebral, visceral, renal, or in their limb. Or they, the second most common cause is dying from aortic insufficiency. And most of those causes of death can be managed by replacing the ascending aorta alone. And so the main part of an operation for a type A aortic dissection is replacing the ascending aorta. In order to do that, there's been a lot of discussion about how best to cannulate patients for cardiopulmonary bypass historically, getting femoral access, either by open access or percutaneous access. In the last 10 to 20 years. Using axillary artery access has gotten a lot of momentum, or using the innominate artery. Another great technique is to get direct aortic access, something that literally, when I was taking my boards, that would have been classified as a critical fail. If you told your examiner that you should cannulate the ascending aorta, you got to take the rest of the morning off because you failed your boards. Now it's actually using TEE and Sellinger technique. It is not only it's a great approach for somebody, particularly if they're unstable. You can get quick and ready cannulation in the ascending aorta. And fortunately, and somewhat surprisingly, the patients don't rupture their aorta while you're doing it. From a practical and theoretical point of view, all of the different approaches have their own advantages and disadvantages. I think it's important to understand and to take advantage of the advantages and to get away from the disadvantages. People have looked at what are the best approaches, and if you look at, this is a meta-analysis of a number of different studies, and the majority of those studies would suggest that axillary is superior to femoral access with regard to mortality rates and stroke rates. If you look at how to protect the brain, going back to the work of Bigelow in Canada and the benefits of hypothermia to protect the brain, and a lot of the clinical work, which was done by Randy Greep in the 70s and the 80s, a big part of how we take care of our patients had been and to some extent continues to be with cooling the patient and cooling the brain. Other adjunctive therapies, whether it's retrograde cerebral perfusion that has been championed by Professor Ueda in Japan, or antegrade cerebral perfusion, and there's a number of different ways to achieve antegrade cerebral perfusion that was first championed by Dr. Kozui, also of Japan. It's interesting, maybe many of you know, but retrograde cerebral perfusion was originally described and used to treat patients with massive air embolism to the brain. And it took about another 10 years before Professor Ueda started using it for aortic arch surgery. And again, if an analysis from the STS database of almost 13,000 patients, if you look at temperature and different kinds of cerebral protection, whether it's just cooling the patients for hypothermic circulatory arrest, different degrees of cooling, and adding retrograde cerebral perfusion or antegrade cerebral perfusion. What this analysis demonstrated that whether you're deep hypothermia, and this defined as less than 20 degrees, or moderate low hypothermia, less than 24 degrees alone, that is a increased risk or hazard for developing a stroke. If you do retrograde cerebral perfusion versus antegrade cerebral perfusion, they're statistically similar. If you just do deep hypothermia without any adjunctive therapy, that's a risk from at least this database for mortality in the treatment of patients with aortic surgery. Mario Gaudino and colleagues did a meta-analysis that included 68 studies, almost 27,000 patients, again, looking at cerebral protection. And if you look at that forest plot, whether it's ACP versus hypothermia alone, risk factor for stroke, RCP versus hypothermia, risk factor for stroke more in the hypothermia. If you look at RCP and ACP, they're statistically the same. Mortality, again, that deep hypothermia alone is a risk factor for stroke compared to using some degree of hypothermia with antegrade or retrograde cerebral perfusion. So the most recent guidelines suggest axillary cannulation or central cannulation. Stronger evidence for that as opposed to femoral, in that using moderate hypothermia with some kind of antegrade or retrograde cerebral perfusion is beneficial. So what does that mean? So what does most of the world do? And this is an analysis of the STS database looking at aortic dissection. So almost 7,400 patients, the overall mortality, 17%. Even though we've made a lot of advances in how we take care of patients with type A aortic dissection, still a very high-risk operation in a high-risk group of patients. Stroke rate, 13%. So the most common of the cannulation strategies, axillary artery. But even though it's common, it's not the majority, 34%, followed by femoral and then central aortic. How about temperature? If you look at, so 60% of surgeons still go below 22 degrees, and then mixed about 20% do moderate low or moderate high hypothermia. And 46% do antegrade cerebral perfusion, followed by no antegrade or retrograde cerebral perfusion. So interesting practice across the country. As I mentioned, the prime operation is to replace the ascending aorta and manage the proximal and distal suture lines. As I think many of you know, the tissues are like wet tissue paper. So whether you use fine sutures or you use felt or pericardium in the neomedia or fold over the adventitia, all are equally good, but all require that you use meticulous technique to prevent bleeding and to prevent the risk of new entry tears, either proximally or distally. Many of these patients will have aortic regurgitation at their presentation. Most of these patients will have aortic valves that you can save. There are many different mechanisms that account for the significant aortic regurgitation that are not related to the valve itself, so that by reconstructing the aortic root and resuspending the aortic valve commissures, you can save that valve most of the time if there isn't some kind of organic pathology of the aortic cusps. If there is pathology of the aortic valve, or if there is an aortic root aneurysm to start with, the recommendation is that you should replace the root and replace the valve. In programs and in the hands of surgeons who have a lot of experience, if the aortic valve is a normal aortic valve, doing a valve-sparing aortic root is an acceptable approach, but that's not the kind of patient to learn how to do a valve-sparing root operation on. Again, the primary goal is to keep the patient from dying. There's also been a lot of discussion about what you do with the distal aorta, the aortic arch. I would say certainly in the last 5 to 10 years, if you look in our literature, there's a lot written that would make one think that the expectation is that you should do something to the arch. You should do something endovascularly in an antegrade way to put in some kind of endovascular solution, a frozen elephant trunk, or an actual elephant trunk. And recently, in the last year and a half or so, the Thoraflex graft, which is a composite graft that has a stent graft built into an arch graft that makes the ability to do a frozen elephant trunk and an arch replacement much easier. And I think that in appropriate patients, in the appropriate hands, these are good tools to have. But I don't think that it is procedures that are required or should be expected. And I think if you look at the data and look at the guidelines, arch surgery in patients with acute type A aortic dissections, if you have a patient that's relatively stable, a surgeon in a center that has a lot of experience doing arch surgery, certainly patients who have an aneurysm of their arch should strongly consider replacing that arch. If there's a complex tear, either in the arch itself or just distal to the left subclavian artery, we know that those are patients who are at high risk of having early problems. Those patients who have heritable diseases, whether it's Marfan's or Loeys-Dietz, those patients in the appropriate hands would benefit from an arch replacement. Also, patients who have malperfusion, which is a big source of morbidity and mortality in these patients. If you look at the data from the IRAD database, which is an international registry, voluntary registry, I think they have taught us a lot about how we're doing with aortic dissections. And across the board, for those patients who are managed surgically, it's about a 20% mortality still, patients who are surgically treated with type A aortic dissections. What we've learned from the German experience, again, another big registry, in over 2,000 patients, their mortality at 30 days was about 17%. But not all patients have a 17% risk of mortality. There are patients where the risk is lower, and those patients where the risk is higher. And a large part of that has to do with whether or not they have malperfusion syndromes. So in their data, if you didn't have any malperfusion, your mortality was just over 12%. But with each organ system that has either a clinical or a radiographic malperfusion, that the mortality rate goes up. And so managing that malperfusion syndrome is very important, we think, for reducing the mortality in those patients. As we've learned, there's different causes for malperfusion, whether it's a static or a dynamic cause of malperfusion. The conventional thinking and still the strongest recommendation for patients who have visceral or limb malperfusion is to do a proximal operation first, replace the ascending aorta. Oftentimes, but not always, that malperfusion syndrome will get better by doing that. And if it doesn't, you should manage that afterwards. There is interesting and somewhat compelling data from particularly the group in Michigan that have adopted the practice of addressing the particularly visceral malperfusion, which is one of the highest risks of mortality, upwards of 60 to 70%. And they have either done endovascular fenestration or done TEVAR, get the patient stabilized, see if their acidosis gets better, their lactate corrects. If they do, then a day or days later, we'll take them to the operating room and operate on them. And that some of the data that they've presented has been actually very compelling. For other managements of malperfusion syndrome, there is using flow modulators, the AMDS device. This is a cartoon from a study from the DARTS trial. It was mostly done in Canada. 5 centers, they had 46 patients. And so the observations have been that even when you do an ascending aortic or hemiarch replacement, about 70% of those patients will develop new entry tears at the distal anastomosis that will, even if you didn't have distal fenestrations from the original dissection, you will create them at the time of the surgery. Also, for patients who have distal malperfusion syndromes, replacing the ascending aorta in a hemiarch fashion oftentimes won't impact the flow through the true lumen if it's really pancaked and small. So the concept behind the AMDS device, which for those of you old enough to remember the Slinky, it looks like a Slinky that you put in antegrade. It has a big cuff that you use that to sew your distal anastomosis, and that modulates flow. It's an uncovered stent, so all of the branches, whether they be the brachiocephalic branches or the intercostal arteries, have flow that go through them. And the hope would be it would improve malperfusion and prevent the risk of distal anastomosis new entry, so DANE. And the data from the DARTS trial was very compelling. Again, their mortality at 30 days was 13%. They had a 0% versus 70% incidence of distal new entry tears. No mechanical problems in the placement of this device. This last January at the STS meeting that was in San Antonio, there was the 30-day results and some of the early follow-up of the PERSEVERE trial. Wilson Zito presented this. Dr. Sultan is one of the investigators and part of this important study. It was, I think, 93 patients. All of the patients had malperfusion with the type A aortic dissection. And 80% of those had clinical malperfusion, whether it was signs of visceral, renal, distal, or serial malperfusion. And over 50% of them had multiple organ systems involved in their malperfusion. And you can see what the device looks like. This is a CT scan reconstruction, and at 1 year, the remodeling of that descending aorta and arch is quite impressive. And again, if you look at their results, in the green, so their mortality rate under 10% compared to, again, in these malperfusion syndrome patients in excess of 30%, and there were 0 new entry tears. So very compelling. Doesn't add much to the circulatory arrest time or the bypass time, and it's a much easier device to implant compared to doing a frozen elephant trunk or using a Thoraflex device. How about type B aortic dissection? So if you look at the ratio of type A to type B dissection, so type A dissection makes up about 65% of dissections, type B about a third. Certainly if you look at the survival curves, out to 60 days, it looks as if type A dissections are much more serious, much more mortal disease. And many people have, I think, classified type B dissections as the more benign of the two dissections. And maybe that's right, or maybe it is not right. And I think hopefully I can compel you to think that it isn't that way, but we'll see. So we learned decades ago that the results of surgical management of type B aortic dissections was worse than the medical management of type B dissections, and that over the last 10 to 20 years, there's been more and more use of endovascular solutions. Certainly, if you look at the medical versus surgical management of type B dissections, medical managed patients, by and large, do much better. the difference between the medically managed and the endovascularly managed, hard to know. If you look at the IRAD database, and again, this is a little bit dated information, but if you look in the blue, surgically managed patients, open surgically managed patients have gone down over a period of 20 years. In the red, medical managed patients have gone down proportionally over the years. The number of patients managed endovascularly, that's the green bar, that's gone up over those years. Survival, that's the yellow line, has essentially stayed the same. That was the impetus behind a group from the STS and the AATS to look at the evidence that existed, and we created a clinical practice guideline based on that. If you look at how patients with type B dissections present, so uncomplicated dissections, so those are patients who don't have a rupture, don't have malperfusion, don't have high-risk features. And the evidence would suggest that the recommendation for treatment is optimal medical therapy. Patients who have complicated dissections, so they have a rupture or malperfusion syndrome, those patients are better managed with endovascular solutions. And if they don't have the appropriate anatomy for an endovascular approach, they should be treated with open surgery. Now, these definitions are different from before. Complicated dissection, patients with pain, patients with hypertension, there are all kinds of creeps into calling them complicated. So one of the things that came out of this work was to be very hard and fast on what constituted an uncomplicated, what constituted a complicated dissection. And certainly the evidence is very compelling for using TEVAR in patients with complicated dissection. It should be done in the hyperacute, acute, or subacute phases. And in those patients, as I mentioned, who don't have appropriate landing zones or anatomy, they should be considered to be treated with open surgery. Fenestration, I don't know, that's a very effective, but it's a very difficult skill set to have. I know that the group in Michigan has that skill set, and those patients do very well with it, but it's again, a difficult skill set to learn. What are the goals of using TEVAR in patients who have a type B dissection? Well, first of all, you cover the primary entry tear. It controls the rupture or the pending rupture. You can reestablish flow through the true lumen, which hopefully and oftentimes will resolve the malperfusion and over time help with the remodeling of the aorta and prevent future aortic catastrophes. There's risk to it. Retrograde type A dissections it's been reported anywhere under 1% to as high as 8% incidence. And it doesn't necessarily have to happen right at the time that you implant the TEVAR device. It can happen days later, weeks later, months later, years later. You get a retrograde type A dissection. The risk of stroke and the risk of spinal cord ischemia and paralysis are real risks. If you look at a bunch of the data, though, in patients with type B dissections that are complicated, the evidence is very compelling that treating those patients with TEVAR are appropriate. For patients who don't have appropriate landing zones because of hematoma that extends back into the aortic arch, that don't present good landing zones, the branch stent grafts are now being used to be able to extend the proximal landing zone, and so far the experience with that, the early experience, has been very good. Interestingly, an antegrade approach using a frozen elephant trunk or, in this case, a Thoraflex graft. Oftentimes, particularly if you're managing these with with our vascular surgery colleagues. If they don't have a good proximal landing zone, it's like, well, you know, there's really nothing more we can do. Well, there is. You can use the frozen elephant trunk or Thoraflex device to get appropriate proximal landing zone surgically. So again, as I said, uncomplicated type B dissections, the evidence that we have would suggest that we should continue to treat these patients with optimal medical management, anti-impulse therapy. There are some reports that would suggest that maybe in patients with high-risk features that the prophylactic use of a TEVAR may be considered and that these patients need to be carefully followed. The most compelling evidence for this recommendation is the INSTEAD trial. That was reported in 2009, and this was uncomplicated type B dissection, and they were randomized between optimal medical therapy versus optimal medical therapy plus TEVAR. And the primary endpoint of that trial was all-cause mortality at 2 years, and the secondary endpoints were aortic-related deaths, progression of their aortic pathology, evidenced by the need for reinterventions, and aortic remodeling. In the INSTEAD trial, there was very impressive aortic remodeling in the TEVAR group compared to the optimal medical therapy group alone. But there was really no difference in all-cause mortality, aortic mortality, or aortic-related deaths. So the conclusions, although it was a very limited, literally and statistically trial, that was the justification behind recommending optimal medical therapy as opposed to the use of TEVAR in patients with uncomplicated type B dissection. The investigators, although the study was not designed for this, nor was the study powered for this, took those group of patients and they followed them out to 5 years. And what they found was really fascinating, and I think should make us reconsider how we manage patients with uncomplicated type B dissection. So if you look at these graphs, that the graph shows this is a landmark analysis. So if you look at the data at 24 months, so that was the time when the INSTEAD trial closed, and you look what happens in terms of mortality over time. This is defined by progression, whether it's aortic-related mortality or aortic-related intervention. The patients in the blue are those who were treated with optimal medical therapy. The patients treated with TEVAR are in red. The red line is pretty flat. The blue line is pretty steep. If you look over in the chart, again, OMT, optimal medical therapy, versus OMT plus TEVAR, in the first 2 years, those patients in the OMT TEVAR group, there were more of those patients who died. If you look after 2 years, in this group, there were no deaths in that group. All the deaths were in the optimal medical therapy group. Again, not statistically relevant because of how it was powered, but I do think very hypothesis generating. If you look at the data from the Danish registry, so in Denmark, unlike the IRAD or the German registry where it's voluntary registration, in Denmark, every patient with an aortic dissection is in their registry. It's just part of how they keep their records. So if you look at the long-term survival of aortic dissections, the green line at the top, those are age-matched controls. The blue line is type A aortic dissections, and the red line is type B aortic dissections. You know, certainly once you get past the first year, the type A and type B lines are pretty superimposed, and they both are significantly different in terms of mortality of the control group. If you take the first 30 days out of it and I apologize for the paper because the color of the lines are different now. But the control group is the dark line up top. The green line, which essentially parallels the control group, is the type A aortic dissection patients. And the red line is the type B aortic dissection patients. So that, what we have considered to be the benign aortic dissection, over the long term, has a really concerning mortality curve. And we commonly hear in patients who have a residual type A dissection, after the ascending aorta is replaced, they have a type B dissection. I believe that type A dissections and type B dissections are different diseases. If you have a residual dissection in the descending aorta, I think that's a different disease process than somebody who has a type B dissection de novo. And perhaps that these patients that have uncomplicated type B dissections maybe would benefit from having endovascular solutions in the management of their disease. The problem is we don't have any data to prove that. And I think that's what's happening more and more over the country, is that in the world, is that there's a very low threshold to treat uncomplicated dissections with TEVAR. And maybe that's the right thing to do. Maybe it isn't, until we have the ability to look at that in a controlled prospective randomized trial. I don't think we'll ever know. So to sum up, aortic dissection continues to be a challenging disease, and it requires appropriate diagnosis, prompt management, and the management of these patients over the long term. The technology and our techniques, they continue to evolve, and it's really important that we rigorously study the comparative effectiveness. Guidelines are intended to provide the evidence behind what we do, and if done right, it should be a work in progress. And there certainly are, as somebody was involved in the writing of some of these guidelines, it is incredible how much we do that is based on really not that much scientific evidence. And maybe we're right, but maybe there's more we can learn. And as I mentioned, I think that the management of patients with uncomplicated type B dissection, I think we need to rethink how we do that. And the only way we can do that is to have multi-center, multidisciplinary centers of excellence that we're fortunate to have certainly here in this region and around the rest of the country and the world to help us answer those questions. So with that, I'll stop. I'm happy to take any questions. I'm also happy to let you get back to your salad and your main course. So thank you very much for your time and your attention. Nice to be here.
Great. Thank you, Tom. That was outstanding and great summary. Questions? Go on the microphone.
Thanks again for coming, Dr. MacGillivray. My name is Derek Cern. I'm one of the cardiac surgeons at UPMC. My question is, when you see a patient, say they're coming in with a chronic type B dissection, they've had it for a few years, and your distal landing zone is kind of starting to approach maybe 40 millimeters or 4 centimeters, and you're thinking, well, the grafts only go to about 45, 46. Say the biggest part of the aneurysm isn't huge, but you know that at some point you're going to probably lose the ability to have an endovascular option for them. Is that something that you take into consideration, and you're looking to potentially treat those patients with endovascular options, even though maybe the biggest part of the aneurysm isn't huge, but you know you're going to lose that option in the future? And then secondarily, how do you manage that chronic, the septum? We've tried to open and balloon it and had some issues with that. And my question is just kind of management of chronic type Bs.
Yeah, that's a great question that, at least in my mind, I don't think we have a good answer to. I I think that, as you mentioned, there are a number of different techniques to, the Knickerbocker technique and, a number of different endovascular techniques to try to manage that. If you are going to manage it, in my opinion, endovascularly, you have got to control both the proximal and the distal extent of the coverage. Otherwise, I think certainly if you have a dilated distal landing zone, I think there's pretty good data to demonstrate that that accelerates the aneurysmal degeneration of the visceral segment. Open surgery is less common, but it's not dead. I mean, I do think that certainly in appropriate patients, younger patients, patients who are in good physical condition, I think that certainly if you look at, our recommendations in the guidelines, that those patients should be considered for open surgical repair if there is not good endovascular solutions.
Thanks for such an enlightening talk. I really appreciate it.
Thank you.
Tom, one question I had for you is, there's such a, I used to think there's not much that you and I could disagree on, but I found some things. So, one of the things I think about when it comes to cannulation or cerebral protection strategy, everyone does things so differently. And there's always so much data, and it's not that there's no data-free zone. It's just that, either as a society we're not, first of all, it's a rare disease. As a society we're not, I would say, not have enough resources to do this in a very organized, prospective fashion to know what is the best way to do this, right? Because by the time you see these patients, and with each hospital or center doing just a handful of these 4 or 5 a year, how are we ever going to get to a point where the mortality is not 20, 30%, which is what's reflected in the STS database right now?
Yeah. Yves, that's a great question. And whenever you and I disagree, it makes me worried. It makes me think that I'm not thinking about it the right way. But you're right. I mean, we have data, but I'd say that the data is retrospective observational studies. And so, just because what people are doing doesn't mean it's the right thing to do. And if you look in certainly the STS databases and some of the meta-analyses, the vast majority of surgeons that manage aortic dissections, manage them well. The average number that are done per center is like 1 a year. I mean, it's really incredible. And then there are centers that do, 50 or 100 of them a year. And so it is very difficult to get, even though there's data, it doesn't mean it's good data or meaningful data. Our abilities to be able to design and execute a controlled, prospective, randomized trial for acute type A dissections, it's never going to happen. There are people who have advocated for trying to regionalize where aortic dissections go, which might make having a prospective randomized trial easier to execute. Personally, I'm not sure that's a good idea. I think that I think that certainly the time element. I think there's interesting data that comes out of China. They have huge. I remember talking to Professor Sun at a meeting, and he said, "Oh, I apologize. I'm very tired. I had 6 dissections yesterday." Like 6 dissections. He said, "Yeah, that's not the record. The record was 14. We did 14 in one day once." I mean, that's an incredible experience, as opposed to 1 or 2 a year. But I do think that patients get really well cared for, despite the limited number of patients that are treated. And I think that putting somebody in a plane, who's in Western Montana and flying them to Michigan, maybe that's the right thing to do. I just don't think. I think that having them be treated at a center that I think that's better than regionalizing it. within a city, having 5 centers within a city do it, well, that's a different matter. But we're never going to have a controlled prospective randomized trial.
Yeah, I think today some of us are probably wishing for that regionalization as well here. But I think it's a little less self-serving than most surgeons in our specialty who stand up and say, only I have a 100% mitral valve repair rate. Send them to me because I will do them between 9 and 3 o'clock as opposed to, doing these at 3 in the morning when you regionalize them. But no, that's a great point. Thank you. Any other questions from anyone? Great. Thank you once again, Tom. Appreciate it.
Thanks, everybody.
All right, for the second set of our program, Hero, if you'd like to go up and start with introductions, and looking forward to this fireside chat.
Good evening. I'm really great honor to be here tonight to introduce Dr. Ron Pellegrini. Maybe I don't have to explain about his CV at all, so I'd like to show you some pictures. So here is a couple pictures which was taken when I was in Passment. 20 years ago, I met him at the Presby first. I was artificial heart and the lung transplant fellow. As you know, that the transplant fellow didn't have a case every day. So I went to the OR to observe his surgery. I was so impressed from the cardiac anesthesiology side. So I went there several times, and one day he asked me, why don't you scrub in? So I started as a second assistant because we have a resident at the Presby. But sometimes we don't have the resident in the OR. So next time he asked me, why don't you help me? And finally, why don't you solve the coronary? This is the things I had when I was at the Presby. After the 2 years transplant and the artificial heart program, I was looking for the adult cardiac surgery fellowship somewhere in the United States. I went to Johns Hopkins and the Brigham and the Mayo, somewhere else. But one day, I saw him. This is a kind of elevator talk at the Presby. They just opened the elevator doors, and he talked to me. What are you doing right now? I'm looking for a job. And he asked me, are you interested in work with me? So it was 2006. He is just moving to the Passment. A couple of days later, I saw him in the ICU. I still remember really clearly. So now you got a job. So that's why I started to work with him since July 2006. And I spent 2.5 years. So maybe here in this room, there is a lot of surgeons who trained by Dr. Pellegrini. So maybe you are familiar with this face. We're going to start. But maybe you're looking at this face in the OR several times, looking at me. And he tried to show me the heart, especially mitral valve. Look at here, anterior leaflet here, posterior leaflet is here, paralysis in P2 area. Look at here. Well, I can't see really well. But every single day, we have 2 or 3 cases in the OR at the Passment, as well as that we have a good cardiac anesthesiologist, which is his wife, Donna Pellegrini. She's here too tonight. And after we finish the mitral valve repair, he always look at the right side, which means the cardiac anesthesiologist, which means his wife. Hey, Donna, check my mitral valve with a TEE. Looks beautiful. Water tests show nothing, no leakage at all, like this. Beautiful, no leakage, perfect, no sound, no pressure gradient. But she always said, hey guys, I saw a couple leakage. I saw the 1 or 2 red cells. This was a kind of a dream days for me, 3.5. That's why I'm here. And he completely opened my career as a cardiac surgeon. I really appreciate it. So tonight, I'd like to everybody already know about his surgical technique as a cardiac surgeon, how great he is, outstanding. But also, today's lectures, maybe we can learn from him something like not only the surgeon, but also like a human beings. This is one of the picture, which was 2014. He came to Japan. After when I went back to Japan, we went to a couple places to trip. This is in Kyoto, Golden Temples. And I'd like to introduce his family from the right. This is his daughter, Francesca. She's really beautiful, like his wife. And also next is, of course, Donor and himself. And his great son is Lucas. And me and my son, which was 10 years ago, but was still clear, good memory for me. So please come up here and please present your great presentation. Here is a great speaker, Ron Pellegrini.
Thank you, Hiro. It's a pleasure and an honor to be here to share some thoughts with the future generations of heart surgeons. I want to first thank Dr. MacGillivray for a very beautiful, extensive, elucidating discussion of a very difficult clinical situation. I just have one question for him. Why do these things always happen at 2 a.m.? I'm going to, this talk is not oriented towards informing you about the state of the art today. I want to share with you some historical events in cardiac surgery that paralleled my life. I want to allow you to understand what the practice of cardiac surgery was whenever I went into practice. I also want to go on and discuss some of the philosophy I had about how to do the business of heart surgery and how to develop a large integrated practice. And finally, I want to touch about a couple of things that concern me for the future. I was born in 1936, Western Pennsylvania. 1937, John Gibbon invented the heart-lung machine in a research lab in Boston, Massachusetts. His wife was his technician. In 1949, Charles Bailey did 2 mitral cholesyrotomies on the same day. The first case was done at Hahnemann. That patient died. Dr. Bailey rushed out of the back of the hospital to avoid media, went to Episcopal Hospital and did the second case, which survived. Tremendous, tremendous breakthrough. In 1953, I started my gap year working in a coal mine before I went to college. 1953, Dr. Gibbon did the first successful cardiac operation using cardiopulmonary bypass in which he closed an atrial septal defect on a young woman. I went to medical school in 59. I was all prepped to become a primary care physician. I was on a surgical rotation in 1962. The resident came up to me and said, get up to room 7 right away in the operating room. I went upstairs, when in the operating room, Dr. Gibbon was scrubbed. His young colleague, Rudy Camachon, did a open heart operation on a young patient, and I got to see the machine up close. It took 22 units of blood to prime the machine, which was in the next room and connected to the operating room with tubing to the patient. It's interesting because Dr. Gibbon himself only did one open heart operation using his machine. It changed my life. Primary care went out the back door. I was overwhelmed. 1967. Kolosov in St. Petersburg, Russia, did an internal mammary to LAD graft on a beating heart. I missed Dr. Starr in 1962 in implanting a ball valve in the mitral area of a young woman. In 1968, using cardiopulmonary bypass, Gardner did the first recorded coronary bypass using a vein graft to the right coronary artery. In 1972, I started my that 72 is a wrong date. It's 1970, I started my cardio fellowship at Michigan. And at that time, the Cleveland Clinic spearheaded the treatment of ischemic heart disease with the development of selective coronary angiography by Dr. Soames. And Don Effler and Rene Favaloro developed the technique of grafting obstructed coronaries. This is Dr. Gibbon with a picture of his machine. When I got to Michigan, they had a well-established open heart program, but they did not have a cardiologist that could do selective coronary angiography. My group of cardiac fellows traveled to Wayne County Hospital and St. Joseph's Hospital to work with surgeons who used the Cleveland Clinic technique to do CABGs. This included cooling the patient to 28 degrees, cross-clamping the aorta, doing a 10-millimeter coronary arteriotomy, inserting 16 black silk sutures, 6-0, 16. Every case got 16 sutures. Unclamping the aorta, putting the sutures through the conduit, and tying them down. That way, you could test for leaks in the distal anastomosis and repair them. Then, you would reclamp the aorta and repeat for additional vessels to be grafted. Those procedures that I saw at that time were LAD diagonal and right coronaries. I never saw a circumflex coronary artery grafted in my fellowship, 1970. I came back to Pittsburgh in 72. Before I left Ann Arbor, Dr. Sloan, Herbert Sloan, he was the chief at the University of Michigan. He was the editor of the Annals of Thoracic Surgery for over 18 years. You would dictate an operative note, and he would call you up to his office and correct your grammar with a red pen. That was funny now, but it was not funny then. Anyway, and Dr. Sloan grew up just south of here in Clarksburg, West Virginia. And he was the only man in the state of Michigan that I was taller than. And he was a testy, very anal absolutely superb technical surgeon. I mean, he was superb. No matter how dry the field was, when he walked up to the field and you opened the case, it'd say, "Where's all the blood coming from?" My God. Anyway, he told me I wasn't going to be able to make a living in Pittsburgh. He said, in Pittsburgh, there are 4 prominent cardiovascular teams. Dr. George McGovern Sr. at Allegheny. St. Francis had Jim Jacobine. Dr. William Ford was at Shadyside, and of course, Dr. Bahnsen was at the university. The important thing was all 4 of those programs had their own fellowships. So as their fellows would train, these men would send their fellows to get hospital privileges in the suburban and rural areas to Gardner consults to refer back to the mother house. That was a bitch. I returned to Mercy, and I didn't get a surgical consult for heart disease for 6 months. During my military service, the Sisters of Mercy, who ran the hospital, had contracted with Dr. McGovern's group to initiate an open heart program at Mercy. So I had to struggle to develop a private practice. You have to understand that in 1972, 95% of the cardiothoracic surgeons in America were in private practice. You didn't get a job from a hospital. You had to go out in the street and make it. So what did I do? I subletted office. I borrowed money to buy a house and feed my family. Unfortunately, I depended on the personnel in the sublet office to do my billing, but they informed me after 3 months that they worked for the main doctor in the office and they wouldn't do my paperwork. I had been doing a fair amount of thoracic and vascular cases at that time, but no cardiac cases. Financially, I was in a tough spot. I had 2 kids and a wife and a mortgage. And so what did I do? I got my own office in Southwestern Health Center. I hired one of my mother's younger sisters to be my secretary, business manager, master of all trades. And I tried to read everything I could on how to build a private practice. So here I am, 37 years old. Spent all that time training to be a heart surgeon, and I didn't know crap about how to start a practice. I didn't know how to fill out an insurance form. Who taught you that? When you were a resident of Mass General, nobody taught you that. But mother of invention is necessity, so brick by brick we built a business plan. And we always pushed hard to progress. We made mistakes. We probably lost money. But in the end, we developed a very smooth running operation. And there were 2 issues that were really the keystone of building a successful practice: the patient and the referring doctor. 2 customers formed the foundation of my practice: optimal patient care, communication, and transparency with the referring doc. I cannot tell you that was true then, that's true today, and that's going to be true tomorrow. So, what was the state of the art in 1972? I'm old. It's a word I almost never use. But most of the things on this list are obsolete. There was the oxygenator that Dr. Gibbon used were discs that turned, and the oxygen, it was a closed room. The oxygen went across the disc to oxygenate the red cells. Progress. A bubble oxygenator was produced commercially, which had a blood gas interface, which produced bubbles and foam. And it was very traumatic to the components of the blood. There was no arterial line filter from the pump to the patient. There was no Swan-Ganz catheter. We had to use CVPs. There was no such thing as a transesophageal echocardiogram. Everybody used femoral artery cannulation. You blow crap out of the descending aorta into the brain. The blood bank support was very, very bad. Nobody knew what platelets were. You had to beg the bishop to get platelets. Hemodynamic monitoring was primitive. Early instrumentation and sutures were offsprings of vascular surgery. There was no proline. There was no such thing as pledgets. No one ever heard of cardioplegia. There was no cardiac anesthesiologist. There was no critical care medicine. Who knew what loops and headlights were? They weren't around. The ones that were around, you couldn't see through them. So the foundation at that time in heart surgery was speed, cold to protect the heart and decrease myocardial oxygen depletion, and perfect technique. There are things that I did in my house at Mercy Hospital that I don't think anybody else around town was doing. I put a 40 micron filter in my arterial perfusion line. People thought I was nuts. Aortic cannulation. When I was at Michigan, I worked with the technicians from Sarnes. Sarnes was a company that made the excellent cardiopulmonary bypass machines. And we were having difficulty with tiny little kids with femoral artery cannulation. So I worked diligently with a couple of their engineers, and I developed. I made pictures, drew pictures for them, and they took them over to Sarnes and machined them and brought them back, and we ended up with good aortic arch cannulae. That bubble oxygenator was a killer. You couldn't do long operations with it. Blood would start the urine would start getting red halfway through the case. Well, I got to know Dr. Pierce, who was the chief of cardiac surgery in Hershey, and he was doing research with General Electric on a membrane for heart surgery. I obtained some of these, went to the dog lab and did 5 cases, and they worked. They had a drawback. They weren't big enough for an adult, so you had to use 2 in sequence. But by God, the perfusionists we had developed a technique to use that membrane oxygenator. And what did it do? Well, it prevented the blood from touching oxygen. It was similar in design to Clough's artificial kidney that he was using at the Cleveland Clinic. And it really helped prevent coagulopathies. and I could do longer operations without hurting the patient. At that time, 10% of patients went back to the OR for bleeding because the blood wouldn't clot. You couldn't get platelets. That was just unheard of. You just couldn't get them at my place. They'd give you fresh frozen plasma, and the hematologist would laugh at you. I developed my own technique for coronary artery surgery, and I did this because I had an extensive experience with vascular surgery before I became a cardiothoracic fellow. I knew that these sick hearts were not going to tolerate a joke. They weren't going to be able to go without blood. I also knew that when you cut into the ascending aorta to put the proximals in, a lot of times there was toothpaste in there. That didn't make sense to me. So what I did is I cooled the patients to 28 when the heart would spontaneously fibrillate. I never cross-clamped the aorta. During the cooling process, I implanted the proximal grafts in the ascending aorta. I always grafted the sickest vessel, the target vessel, first. So I was perfusing the suspected ischemic area while doing the rest of the operation. I cooled the patient to 28, fibrillated the heart, no cross-clamping, isolated the segment of artery like they do in off-pump surgery, but I used 2 neurosurgical clips called Heifetz clips to do it. Atraumatic. And I thought using silt sutures was nuts. And putting 18 sutures in just didn't make sense to me. So I used Mersaline. Anybody hear of Mersaline? It's a woven Dacron that had a coating on it. But in order to use it in a vascular anastomosis, you have to run the stitch because it's unforgiving. You can't pull it up like you can Proline. But I had my first assistants run the suture. When I did mitral aortic valves, you have to cross-clamp the aorta. There's no retrograde cardioplegia. Putting the heart in ice precipitated events called a stone heart syndrome, which was just ischemic contracture. I wanted to avoid making the heart ischemic. So I cannulated the coronary arteries and perfused them while I did the aortic valve replacement. It took a little longer, but it was not that challenging once you got used to it. For mitral valve disease, at Michigan, we frequently did mitral valves through the right chest, so I did that. But I didn't clamp the aorta. If you cool to 32 degrees, you get bradycardia. If you do not retract the heart hard, you don't give them an AI, and you can do the mitral valve through the right chest or even through a sternotomy. The main thing that I used to help get good results was avoiding global myocardial ischemia. You have to remember, cardioplegia wasn't even thought of then. But cardioplegia has been a boom to heart surgery. So I was a lone ranger for a good while, which was a 24/7 job because there was nobody working in the ICU but me at night and on weekends. Anyway, excellent results produced more referring doctors. The practice, it would be egocentric for me to say exploded, but it did. The practice just kept growing. So we increased our numbers, and then we decided that patients who lived in counties outside of Allegheny deserved good medical care. So we established open heart programs in 6 sites. Some county seats, St. Clair was not outside of Allegheny County, but Butler, Washington, etc. All the sites. So we're deluding ourselves. We've got new surgeons. We have people here, there, and everywhere. So how do you maintain quality control? How do you maintain the fact that each and every patient gets optimal cardiac surgical care? Well, you do it by everyone accepting the fact that they're not a hero. We use the same protocols, the same surgical technique as an integrated team. You could be doing a case and he could go relieve you and not even miss a step. But change is an opportunity to be better. So you want to have a continual quality improvement program. So how do you do it with 6 sites? Because everybody gets together, discusses potential change, and then when change comes about, everybody does it in lockstep. Lockstep, no exceptions. For example, I used Ryder instruments to do the distal coronary anastomoses with 6 and 7/0 suture. One of our young surgeons came back with the idea that we should switch to Casavaleos. Well, it took me 10 to 11 minutes to do a distal with the Ryder. Once I mastered the Casavaleo, I could do the distal anastomosis in 7 minutes. That counts. So if you do 4 grafts and you take 4 minutes off every graft, that's 28 minutes of less ischemic time. That's 28 minutes of less injury to the heart. You all are in the same game. The organ we deal with has to work when we're done fussing around with it. I know there's a lot of new support systems, but they didn't exist whenever I was trying to master my trade. So, how do you maintain and grow a referral system? Communication. The day of surgery, you call or email the referring doctor. Always, without exception, always notify the referring doctor of a misadventure or a death. You know why? Because the family's going to walk into his office and say, "How's my Uncle Charlie? Uncle Charlie died yesterday." That leaves his pants down around his knees. That doesn't produce continued referrals. That's a bad thing. The death of the patient is bad, but not telling the referring doctor and keeping him on board is a disaster. At discharge from the hospital, you have to communicate with the guy who sent the patient. You have to tell him what operation he had, what his course was like, what his medications are, and most importantly, that patient needs to have an appointment to go back to the referring doctor. And when that patient comes back to your office for his follow-up visit, your progress note has to be a letter to the referring doctor. And if there's something wrong, you got to call that guy if you want more patients. Looking back, what are some of the major milestones that happened in our specialty? Well, Dr. Gibbons, he should have won the Nobel Prize. The invention of the heart-lung machine, in my mind, ranks with penicillin and insulin. I mean, just think of the impact that that man has had in the entire world. From a laboratory in Boston. Use of the Swan-Ganz catheter. We didn't have those. So if you don't have a Swan-Ganz catheter, how do you know what the cardiac output is? Huh? Guess. I think after the pump, I think Buck Burke's contributions with his research and application of cardioplegia was just mammoth. Why? Well, it allowed us to operate on sicker people, do more complex surgery, and I think it helped surgeons who struggle a bit technically to get by. It made good surgeons absolutely excellent. Dr. Carpentier's repair techniques for degenerative valves was a tremendous benefit. You know, the mitral valve, it got people in trouble with rheumatic fever, and it was really a disaster in the 50s and 60s. That's why Bailey's fortitude to do that was so important. And the development of tissue valves and dependable mechanical valves has also been very, very important. How do you maintain quality? How do you do it in all these sites? Conformity, same pre- and post-op management, same operative techniques, same perfusion, same suture material, same technique. If you have multiple individuals in your group, you have to have teamwork. There's no room in cardiac surgery for the Lone Ranger. I firmly believe in this day and age, as we move further and further to large groups working together, there has to be some constant that molds things together. Some things I learned. New fellowship graduates are universally overconfident. The new surgeon syndrome. They always make errors of commission, not omission. New graduates are not prepared to be independent surgeons. It requires 5 to 7 years for maturation for a cardiac surgeon to obtain his individual maximum skill level. And that level varies with each individual. That's important. So when I started acquiring associates, when we went to this 11-man team, make no mistake, there were some people that failed to make it. And we had to cut them loose, which is a terrible thing to do. It's a terrible, terrible, terrible thing to tell a 35-year-old guy who's trained all his life to be a heart surgeon, call him in and say, dude, you don't got it. You can't do this. In retrospect, it's really doing him a favor to make that judgment, if it's a correct judgment. Not only are you going to save potentially patients' lives, but you are going to redirect his career to where he can be more successful. To maintain an individual who does not have the skill to be an adequate cardiac surgery is not appropriate. As distasteful as it is to terminate somebody. So the new guys always scrub with me every day. He'd do one case, I'd do the other one. There's a lot of bitching and moaning in the beginning, but things sort of smooth themselves out over a 12-month period of time. I said there was no exception. There was one exception. We had a woman surgeon, Kathy Grant, whose mother was a seamstress, and she was a better surgeon than me when she came on board. She was incredible. The other thing about Kathy Grant, she wasn't a one-horse pony. She made the highest grade on the boards for thoracic surgery the year she took it. All cardiac surgeons are not created equal. Always put the surgeon in a situation to succeed, not to fail. If you're running it, you have to be smart. Triage is appropriate. I moved to UPMC in 1995 after spending 23, 24 years at Mercy and being the head of this big private practice group. One time we were doing 3,500 open hearts at these 6 sites. It was a reverse career change from a very successful private practice to an academic center. There were any number of challenging situations at the university that required difficult decision making. For instance, I walked into the operating room a couple of days after this thing was getting started, and they took me to a room that had cannulas and sutures and stuff, and they had Dr. So-and-so here, Dr. So-and-so here, Dr. So-and-so here. I couldn't get over it. It took my breath away. So I told the nurse manager of the operating room, I said, it's 2 p.m. I says, I'll be back here tomorrow morning at 6 o'clock. I want this goddamn room empty. And I'm going to give you a list of things tomorrow to put in here. And everybody is going to use what I put on that list. And if they don't want to use it, here's my pager number. Nobody called me. So anyway, Larry Way and my son Dan went up there, and we were doing 1,200 open hearts a year, the three of us. But the greatest joy in being there was being able to teach cardiothoracic fellows. I mean, I love taking care of patients, but I really enjoyed the interaction with tomorrow's heart surgeons. I left there after 15 years, and I went to work for Allegheny Health System. I want to say something about the McGoverns, because when I came to Pittsburgh, when I was a resident in general surgery at Mercy, Dr. McGovern Sr. used to come over there and do non-cardiac surgery. And have as not, I was always assigned to help him. And he was a young guy. I don't know, he must have been in his 30s, maybe early 40s. but he was a nice man, and he was a good teacher. And he didn't know me from Adam, but he took time to teach me. When I came back to Pittsburgh, he couldn't have been any more gracious to me. But some of the other people, when I first came back to Pittsburgh, weren't quite so nice. George Jr. saved Allegheny Health System by his leadership and his force of character. He prevented Western Pennsylvania from having a monopolized health system. He's trained a lot of people. He's a good friend. I spent a year up at Conemaugh in Johnstown mentoring 2 young surgeons who wanted to learn how to do complex surgery, primarily advanced aortic root surgery and mitral valve surgery. They have a struggle. Their infrastructure does not match their quality of cardiac surgery because they're both excellent surgeons. I finally retired after my contract was up there. I went to Excella for a while and helped mentor a surgeon for a year, and then I helped develop a heart institute that they are in the process of developing. I spent a lot of time trying to educate the CEO about heart disease, all the different parts of heart disease. For instance, we had a wonderful discussion about aortic dissections. They have never done an aortic dissection at Excella. They sent them all out, which probably because of the quality of surgeons that were there before we got there was appropriate. 35 minutes in the car, you're dead with a dissection, you know, helicopter or not. So I said we're going to talk a little bit, touch on some philosophical nonsense that goes through my head when I'm in my office. Catheter-based aortic valves is a wonderful addition to our armamentarium. But it's an industry-driven application. Perhaps overused. But more importantly, using TAVR will deny the development of young heart surgeons the experience of doing surgically implanted aortic valves. The volume has, I'm sure, plummeted. A TAVR is a tissue valve, but it is not a surgically implanted tissue valve. It's different. It's constructed different. The pericardium is treated differently. And our cardiology friends go into the patient and say, we want to save you an operation. You know, tissue valves last 20 years, and we can put one in with a catheter, and you don't have to be operated on. All those statements are true, except they're not related to one another. The tissue valve on the catheter longevity is 10 years or less at last counting. So what's going to happen? So they're going to fail. And they are beginning to fail, and you senior guys are beginning to see them. So we have a whole generation of heart surgeons who were denied the experience of learning how to do aortic valve surgery in a complex manner, who are now going to be required the Herculean task of replacing a TAVR, aortic valve. That is a technically challenging operation. I don't give a damn who the surgeon is. That is a technically challenging procedure. So you have an inexperienced guy who wants to do it, but he doesn't have the tickets to do it because he was denied the learning process. So the early data, and this is early data, is 15% mortality for a redo with a significant stroke rate. It reminds me of what was going on in 1972. Aortic valve surgery in 1972 had a 20% mortality rate and a 5 to 10% stroke rate. And a repeat history. So I think we're going to have a rather significant mortality rate for redo TAVRs. And you know, if you step back and look at the history of stents, it's parallel to the history of TAVRs. And we have a new stent. It has a different flavor. It's not chocolate anymore, it's vanilla. It'll last longer. That's what's going on with TAVR. I'm emotionally upset about what's going on in American medicine. It's totally out of control. The whole spectrum of what doctors depend on. Health insurance companies, United Healthcare and CVS Aetna are two companies in the top 5 companies on the Forbes 500 list. Aetna's profit margin last year was criminal. It's billions of dollars of profit. There's only one way these companies can generate this money. They ain't taking care of patients. They have to divert the profits from the patient care to the stockholders. What's going on in the big pharmaceutical companies is criminal. You can buy drugs for 1/4 what you're paying in the United States if you go across the Canadian border. Capitalism made America great. Capitalism is a Darwinian method, survival of the fittest. Capitalism is attempting to deprofessionalize medicine. Make no mistake. I don't know how many doctors Optum right now employs. I think it's something like 90,000. They don't have doctors working for them to make the doctor better. They're not taking care of patients better. Healthcare is an entitlement. Capitalism does not work for healthcare as the patient suffers. And we're all exposed to the nonsense of nonprofit mega health systems. Really? Nonprofit? CEO makes, in Houston, the CEO of Anderson, MD Anderson, makes $11 million a year. The lady running UPMC makes $7 million. What the hell is she doing for the patients? I mean, really, how out of kilter are we? It's broken. And it can't be fixed until a socio-political society recognizes the essence of health care. It's the patient, it's not the profit. And profit, unfortunately, is contaminated with greed. We have a problem here with this last slide. Did we erase it? The patient always comes first. Doctor, do no harm. Attention to small detail prevents major problems. All innovation is not progress. Doctor, it ain't what you can do, but it's what the patient needs. Thanks for your attention.
Well done. Well done. Well done. So, Ron, it's great to see you again. I had a bunch of questions that I had written, trying to draw out of you all the lessons learned from your, if I did the math correctly, almost 50-year career. And not surprisingly, you did all the work and anticipated the questions and gave a great talk that I think was had us wrapped for the entire time. I came away thinking that I wish I heard this talk, or I wish I met you 20 years ago when I was starting my practice, but
I wish we would have worked together. I would have enjoyed it.
It would have been great. I think with that, we can open it to questions from the floor, or remembrances. I know there's lots of people here who trained or worked with Ron. Or all of you, like me, recognize that that was a perfect talk. With that, we can close the evening by, I think, once again, importantly, thanking Angie, without whom this would never come together. She's the brains and the brawn of the operation. Thank you all for coming. It's a fantastic third gathering of the West Penn STS. Important announcements. The bar will remain open until 9:30, and will be kicked out at 10. Yes. This ends up being our one event for this year. We're not going to get back together again in the fall, as this was postponed from the spring. But we will be reaching out for ideas on topics and guests and the plan for our spring date. So thanks again, Ron. Thanks, everybody, for attending. And stick around and have a drink and continue the most important work, which is socializing and seeing one another. Thank you.